All right. Hey, everyone. Good morning or good afternoon, depending on which coast of the country you are joining us from. It's really great to see everyone. Looks like we have a pretty diverse group, which I'm super excited about. Um, Excited to be hosting the third of our monthly webinars here at Soul Mental Health. So today we're going to be chatting about a topic that has been front and center in a lot of pop media, as well as a lot of the clinical and scientific literature over the last 3 to 6 months around mental health, and those are psychedelics and next generation therapeutics. This is a topic that we as a outpatient mental health group get many questions about. I have no doubt I see a lot of primary care and specialty care docs and clinicians on this call that you have patients who ask you about some of these molecules and therapeutics as well. So we thought it would be a useful and fruitful topic for a webinar to just give a nice broad overview of psychedelics and next gen therapeutics in mental health, with some specific details on where the science is, as well as some of the most promising molecules and treatments that are coming down the pipeline, so that each of you has a nice broad foundational knowledge of this area and can speak to it when you get questions about it from patients or peers. We have this set up as a webinar. Everyone should see on your Zoom platform a question and answer module, or you should be able to click and open up a question and answer window. So if you do have questions, please drop them into that window. My co-host Jen and I will be monitoring those over the course of the webinar, and I'll either pause and can address those sort of in real time, or we'll certainly save a good amount of time at the end here for any questions that folks had or have, and make sure we address those and answer those. So with that, let's get things kicked off here. Just as a quick introduction, I see some new names and new faces who haven't been on our webinars before. I'm Arpin. I'm the Chief Medical Officer here at Soul Mental Health. We're a next generation outpatient behavioral health group that is taking care of patients across many communities in the United States. We have offices in Colorado, Texas, New York, as well as Washington, D.C., Virginia, and Maryland. We're really reinventing the outpatient mental health experience, wanting to bring high quality and accessible care to our communities in an in-network model, so that's affordable, and doing both psychiatry and therapy together under one roof to provide the best outcomes for our patients. So if anyone has questions or wants to connect about opportunities to collaborate, opportunities for the Soul Mental Health team to support your primary care specialty group or practice, don't hesitate to drop me a line and reach out to us. And then for those of you who haven't met personally, it's really nice to connect. I'm a double board certified psychiatrist by training, boarded in adult psychiatry as well as addiction medicine, and have been practicing for just under a decade now, trained in New York City, and have been with Soul Mental Health for just under 2 years. So what are we going to talk about and cover today? First, I think it's really important to just make sure we're all bottomed out on terminology. There's a lot of words that folks use to talk about psychedelics and next generation treatments. I want to make sure we all have kind of a good foundational set of definitions so that when one term gets used over another, it's super clear what we're referring to. Secondly, we'll do a very high level overview of the mechanisms of action for next gen treatments before we dive into the specifics of both ketamine as well as the group that we'll refer to as hallucinogens. And again, we'll get into what hallucinogen actually means. After we talk about some of the efficacy and evidence, we'll talk about some of the medical risk of these next generation treatments. And then we'll round things out with sort of the legal status of these compounds and what's coming down the pipeline. Again, any questions, feel free to drop them into the Q&A. Happy to take those as they come, and then we'll also make sure we save at least 15 minutes at the end for any questions that come up. I'll also preface before we get into the content with, what we're going to go through is a very, very high level overview. This topic of psychedelics and next generation treatments, it could be and is, a 3 or 6 month full-time course. So we're going to try to hit the most salient points and some of the most critical pieces to give y'all sort of a foundational background and focus on the molecules and compounds that are closest to being commercially available. Oh, and then I just saw a question about having access. So yes, we're recording this. The recording will be made available to everyone who registered. We'll follow up in an email with everyone with the content. There's also an opportunity to earn one AMA Category 1 CME credit, and the follow-up email will include links to claim your CMEs as well. Thanks for the question. So let's kick it off with terminology and classification. So these 3 terms get thrown around a lot in not just popular media, but also in the medical community. But they're not exactly interchangeable. And I think it's important to spend a minute to just clarify that. When we think about these 3 terms, I want us to think about psychedelics as an overarching kind of high-level category. It includes a wide range of compounds and substances. 2 subcategories of psychedelics are dissociatives and hallucinogens. We're going to get into each of those categories separately, but I think it's important for us, particularly for the folks on this webinar who are clinical professionals, to understand the nuance here, that a psychedelic is a really broad term that includes many, many different compounds, and we'll get into that. And then 2 subcategories of psychedelics are dissociatives and hallucinogens. So what is a psychedelic? Quite literally, a psychedelic is any compound that can induce an altered thought and or altered state of mind or sensory state. As you can imagine, there are many molecules, many compounds, many medications, many substances that fall into that category that meet that criteria. When we think about the 2 subcategories of psychedelics, let's think about dissociatives and think about hallucinogens. So dissociatives have a specific sort of end effect and impact, which is they create a feeling of disconnection from one's body when used at or with particular doses. The most relevant dissociative for our conversation here today is ketamine. So very kind of technically speaking, ketamine falls into the dissociative category here. We throw ketamine around and it often gets bunched in with the other hallucinogens, which is fair because they're all psychedelics. But, I want everyone here, one key takeaway here is that ketamine is actually a little bit of a different molecule and a different compound than the other next generation therapeutics that technically fall into the hallucinogen category. Now, ketamine is not the only dissociative that exists on Earth. There are some other compounds, some that have clinical and medical uses, and some that may not, that fall into the dissociative category. So nitrous oxide is a dissociative, dextromethorphan is a dissociative, and PCP is also a dissociative. So a few other examples of compounds that fall into the dissociative category. For the purposes of today, when we say dissociatives, let's make sure we're linking ketamine to dissociatives. Then, when we think about hallucinogens, what is a hallucinogen? Again, technically speaking, a hallucinogen is a molecule that creates a vivid sensory experience in the absence of external stimulus. Again, for the clinical professionals and on the call, that's not surprising. We all know what a hallucination is. And it is, quite literally experiencing sensory experiences without stimulus in the environment, whether it's auditory, visual, tactile, olfactory, or other. What are examples of hallucinogens in the context of next generation therapeutics? There's many here, right? There's probably a list of a dozen or more. For the purposes of today, since I don't have all of you for 6 hours, we're going to focus on 3 hallucinogens, 3 key compounds that I want each of you to understand at a foundational level, and also have a sense of kind of what the next 3 to 6 to 12 months looks like for these compounds. So we're going to focus on 3 hallucinogens: DMT, MDMA, and LSD. So we're going to go to psychopharmacology next. But before we do that, just to recap the key points here, psychedelics are a broad class of compounds. Let's think about 2 categories of psychedelics: dissociatives on the one hand, hallucinogens on the other. When you think dissociative in the context of mental health treatments, think ketamine. And when you think about hallucinogens in the context of mental health treatment, think DMT, MDMA, and LSD. Perfect. See a question coming through from one of our attendees asking about PCP and dextromethorphan being taken as medication for bipolar disorder. That's a good question. I haven't necessarily seen compelling data on PCP being used in the treatment of bipolar disorder. There is maybe more interesting data on dextromethorphan potentially being therapeutic for some psychiatric illnesses and diseases, but that's very, very early stage. And when we're going to talk about kind of DMT, MDMA, and LSD and ketamine as being much more sophisticated from the perspective of we have a good sense of what the therapeutic kind of uses of those compounds look like. But good question. So how do these molecules and compounds actually work? And again, we talked about how dissociative and hallucinogens are a little bit different in terms of the experience a user has. There's also a different underlying mechanism of action. So another distinction for us to draw between dissociatives and hallucinogens. So when you think dissociative, I want everyone to think about NMDA. And the primary mechanism of action for a dissociative, i.e. ketamine, is antagonism of NMDA in the central nervous system. And what does that do? That leads to an increase in glutamate concentration. So dissociatives are their downstream effect that's driving their therapeutic impact in the context of ketamine is glutamate. And then when we think about hallucinogens, when you think hallucinogen, I want everyone here to think 5-HT2A. So 5-HT2A is the 2A subtype of the serotonin receptor in the central nervous system. And hallucinogens are agonists of that receptor, which ultimately leads to increases in serotonin concentration or serotonin-related effects and impacts. So again, a distinction to be drawn, right? So we talked about dissociatives and hallucinogens creating different experiences for people who use them. There's also different underlying mechanisms of action. So when you think ketamine, high level, broad strokes, think NMDA and glutamate. And when you think hallucinogens like DMT or psilocybin or LSD, think 5-HT2A and serotonin. Now, you might sit there and see this slide and then ask a question, which is, well, if they have such different underlying mechanisms of action, why do dissociatives like ketamine and hallucinogens like DMT, MDMA, and LSD ultimately have positive therapeutic effects on similar diseases, right? On anxiety disorders, depressive disorders, and trauma-related disorders? The answer there is while the underlying mechanism of action is different, they actually share downstream effects that are likely responsible for their eventual therapeutic effect. So what we see on a molecular level is, despite one kind of impacting NMDA and glutamate and the other impacting 5-HT2A and serotonin, the downstream cascade actually ends up being shared, which is an increase in a neurotrophic factor called BDNF, or brain-derived neurotrophic factor. And what we see is in patients or in folks who have an increase in BDNF, this leads to an increase in neuroplasticity. So we see improved nutrient growth, an increase in synapse formation, as well as synapse strengthening. So even though these two types of compounds have different underlying MOAs, we see kind of a shared pathway of how they allow the brain to be more resilient. And the hypothesis here is that this is what ultimately helps drive the clinical efficacy in treating psychiatric diseases and psychiatric symptoms. So now that we have a good foundational sense of the categories of psychedelics, their kind of molecular mechanisms of action, and what the likely sort of clinical impacting mechanisms are, let's go into each category. And we're going to start here with ketamine. So what is ketamine? I think of all the substances we're going to talk about or molecules we're going to talk about today, ketamine is the one that most of us are most familiar with, given it's already been used in clinical medicine for decades. So just a quick kind of historical context recap. Ketamine was actually synthesized in the early 60s in 1963. And it was first synthesized as a replacement for PCP, which was also being used for some clinical / veterinary purposes. We first saw it used clinically actually in veterinary medicine in 1964, shortly thereafter, primarily in Europe. About 5 to 10 years later, the FDA approved ketamine for use in the United States as an anesthetic. And for those of you who are primary care docs or surgeons or have worked in the ER or OR, you know that we use ketamine today relatively frequently as an anesthetic. And it's quite efficacious. It's only recently, though, that we've seen ketamine and ketamine-related compounds being more and more frequently used for psychiatric indications. So S-ketamine was approved for its first psychiatric indication in 2019, and then for a couple subsequent indications in 2020. And S-ketamine, just so we're on the same page, is a specific intranasal formulation of ketamine. So it's one specific molecule that has official FDA approval for psychiatric indications. And what is the clinical efficacy of ketamine? It's really effective. It works, right? So we have a very robust clinical literature that supports ketamine's efficacy in not just treating major depressive disorder, particularly treatment-resistant major depressive disorder, which we'll refer to as TRD for the remainder of the webinar. There's also really robust literature in ketamine's ability to treat and manage acute suicidal ideation, as well as treat depressive episodes that are part of a bipolar 1 disorder presentation. So just to pause here for a second, it's pretty groundbreaking that this molecule that's been around for 50, 60 years now, just in the last 4 or 5 years, we recognize and realize that it actually is quite effective in treating clinical diseases that up until now didn't have fantastic options, right? So when we think about treatment-resistant MDD, quite literally, that is MDD that has not responded to multiple courses of our kind of first, second, third line treatments. So ketamine came in and has come in and is a really effective tool in helping manage symptoms for folks who haven't been able to find relief through our first, second, and third line, medications, as well as psychotherapy. And the side on acute suicidal ideation is maybe even more compelling. Up until now, there's not really been any pharmacologic intervention that was effective in treating acute suicidal ideation. So the fact that we've now identified ketamine as a molecule that in the matter of minutes to hours after administration can dramatically reduce acute suicidal ideation is pretty groundbreaking. Now, most of the data that we have on ketamine focuses on intranasal and intravenous routes of administration. We talked about intranasal as being the S-ketamine molecule, which is a branded product today. And intravenous is actually an off-label use. So there's no FDA approval for psychiatric indications of IV ketamine. That being said, there's a very compelling argument to be made that the data is strong and the benefits of IV administration of ketamine for folks, particularly folks with treatment-resistant depression, far outweigh the risks. And we'll talk about those risks here shortly. One interesting piece to spend a couple of minutes on is this idea of oral ketamine, PO ketamine. Over the last 3 to 5 years, mostly since the pandemic, there's been an interest in, can we package ketamine in an oral formulation, typically in a lozenge, and make it more accessible to patients. Part of that push has been because IV ketamine, as we'll talk about shortly here, and even intranasal to some degree, requires some medical monitoring given potential cardiorespiratory impacts. And part of the idea is if we do this orally, can we avoid some of the medical clinical risk? Now, that very line of logic actually also should raise a flag as far as efficacy, right? The reason PO ketamine has lower kind of cardiorespiratory impact is it's actually relatively not bioavailable when taken orally. Its metabolism is also relatively unpredictable when taken orally. So by very definition, its low bioavailability orally means it doesn't have a ton of side effects, but it's also going to have potentially questionable efficacy when taken orally. So for the PCPs who are on the webinar, if I had to hazard a guess, I would say some proportion of your patients may be getting oral ketamine from a variety of places. There's many clinicians and groups who use compounding pharmacies to manufacture ketamine lozenges. And my recommendation would be to kind of approach those with a little bit of caution, just given there is an unpredictable bioavailability. And we're unsure what the ultimate kind of efficacy is given the low bioavailability from the PO route as well. Finally, and we talked a bit about this on the last slide, what's the time to action, time to effect for ketamine? It's fast. So with both IV ketamine and intranasal ketamine, again, we know bioavailability is very high. In the literature, we see that IV ketamine's behavioral health and mental health effects, they begin as quickly as 40 minutes post-infusion. They actually peak around 24 hours. So it continues to kind of work in an increasingly better fashion over the first 24 hours and actually remains superior to placebo for almost 10 days post-infusion. So that's been a really critical finding with ketamine. There were initial hypotheses that maybe patients who use IV ketamine feel better because they're literally intoxicated. But the fact that the treatment, that the patients actually have better remission of symptoms for 10 days post-infusion kind of nixes that hypothesis in the bud, because obviously folks are not having acute impacts of ketamine use 10 days later. There's something else happening in the brain. And that's probably related to what we talked about earlier. It is the NMDA to glutamate and ultimately causing an increase in neuroplasticity driven by the BDNF neurotrophic factor. Cool. So I had a question come in about what SSRI to prescribe with ketamine for patients who have bipolar 2 disorder or bipolar 1 disorder. That's a fantastic question. It probably requires more nuance than we can get into here, but just at a high level, when we think about depressive symptoms in bipolar 1, bipolar 2 disorder, certainly there's a few different approaches that one could take. What we want to avoid is creating a situation where we are sort of treating the depressive symptoms and not protecting against potential mania or hypomania, right? So you can choose from a wide range of SSRIs or even atypical or second generation antipsychotics, right? Which have good efficacy for mood symptoms in bipolar 1 and 2 disorder. what we want to make sure we would do in those situations, or let's say we're using ketamine, is making sure there's a mood stabilizer on board as well, to make sure we're preventing the development of a hypomanic or manic episode. And lithium is also a very fair choice in those situations, given we know that lithium is a fantastic mood stabilizer. Lithium is also one of 3 medications now that we have in psychiatry that independently reduces the risk of suicide, right? There's only 3 meds that we know of today that have an independent reduction in suicide risk. Lithium is one, clozaril or clozapine is number 2, and now we know ketamine is number 3 in that group. Good question. So ketamine is efficacious. I think there's no question about that. Now we talk about what are the potential risks of ketamine use. I like to break them down into 3 separate categories. Think about psychiatric risk, cardiac or cardiorespiratory risk, and genitourinary risk. When we think about psychiatric risk, these are, the impacts that one would feel directly as a result of the dissociative mechanism of ketamine, right? So folks who are prescribed ketamine, when they use it, they're going to experience potentially some level of dissociation, some amount of potential for psychosis. And psychosis could be delusion type symptoms like paranoia, or they could be hallucination type symptoms like auditory visual hallucinations. And there's also a risk for misuse. Ketamine is certainly a compound and substance that in high enough doses does create a euphoria and intoxication, which can, in a patient who is predisposed to it, lead to the development ultimately of a substance use disorder. On the cardiac side, I think most of the primary care clinicians who are on this webinar know better than I. When we use ketamine, particularly in an IV route of administration, like in the OR or in the ER, like you need to have those patients on a monitor, right? Because ketamine can cause tachycardia, it can cause hypertension, can cause arrhythmia. Ultimately, if a patient develops like an arrhythmia, it could actually lead to, poor perfusion and hypotension. So that's why when we see groups and models of IV ketamine infusion, typically that also requires or involves some level of cardiac monitoring or cardiorespiratory monitoring for some period of time after the infusion to make sure patients are remaining stable. And then there's also a good amount of literature that bears out some genitourinary risks with the ongoing chronic use of ketamine, including potential hematuria as well as urinary retention due to some impacts on the bladder and bladder function. That being said, there's ways to mitigate these risks, right? The most obvious is monitoring vital signs, which again is why with both IV and intranasal to some degree, best practice is to have patients stay in the clinic or the site of administration for some time so they can be observed. And we can check their vitals or have them on a monitor to make sure they remain stable. And behavioral observation helps us mitigate the psychiatric risks, right? So making sure there's eyes on the patient, whether it's someone checking in on them and they're in a calm and safe environment for every 15 minutes or every 30 minutes. Some of the at-home treatment models utilize like remote video monitoring, where a patient sets up a webcam or their phone, and they sort of have someone who they can talk to or connect with if they have questions. So like every treatment and every intervention in medicine, ketamine comes with its own risks and benefits. But the literature is clear that if we keep the risks in mind and we put into place a plan to mitigate the risks, the benefits, particularly for patients who have treatment-resistant depression or acute suicidal ideations, can far outweigh the risks that we see here. Couple questions I'll pause here to answer. So one question on the previous slide when I'm talking about ketamine oral versus, and what about sublingual? It's a fantastic question. We know the bioavailability for sublingual ketamine is closer to and more closely mimics the intranasal route of administration. So it's a very good call out that, a lozenge that's purely oral is going to have potentially unpredictable and poor bioavailability. If you have a patient who's taking a sublingual formulation of ketamine, think it's a much more reliable format where there's more consistency of bioavailability, and we can probably be more certain of the therapeutic effect that a patient is going to have. And then another question on, is ketamine contraindicated for patients with bipolar 1 disorder due to possible induction of mania? Fantastic question. I'm not sure I would call it an absolute contraindication. And there is data in the treatment of depressive episodes of bipolar 1 disorder with ketamine. It just has to be done carefully in a controlled environment, right? So in those patients, we have to really make sure we are covering them with a mood stabilizer to prevent a mania or manic episode. In those situations, however, it can be helpful to use ketamine to treat a major depressive episode for a patient who has bipolar 1 disorder. So it can be done as long as it's done thoughtfully and safely. And typically, I would recommend that happens either under the direction of or in close collaboration with a psychiatrist, right, who's really monitoring the patient's behavioral health symptoms. All right, so that's ketamine, right? It's been around for 50 years as a medication, primarily in anesthesia, and just came kind of to light in the last 5 to 6 years as a psychiatric medication as well. Now let's talk about the other side of psychedelics, the hallucinogens. I'm going to focus on just 3 hallucinogens, like I mentioned up at the top: DMT, MDMA, and LSD. The reason I chose those 3 is these are 3 that have been designated as breakthrough therapies by the FDA. So they have the clearest route forward to clinical trials, FDA approval, and ultimate commercial availability. There's dozens of others that also have good data, but they're not so close because they don't have breakthrough therapy status yet. So that's how we decided to focus on these 3 for this webinar. So what's DMT? DMT, also known as N,N-dimethyltryptamine, is a psychoactive compound found in a number of naturally occurring plants. There's a few kind of subtypes, right, or related compounds to DMT. So psilocybin is an analog of DMT that comes from the psilocybe mushroom. Ayahuasca is another analog of DMT that comes from the bee capi plant that's also found in South and Central America. DMT is not new. Ketamine was synthesized in the 50s and 60s. DMT has been used for centuries in spiritual and healing rituals by indigenous populations across Central and South America, and probably in other parts of the world as well. It only became illegal in the United States in the 60s. However, there was a resurgence of interest in DMT and related compounds in the early 2000s. And Johns Hopkins was actually the first to grant approval for the first clinical trials in the DMT family in the year 2000. And that was specifically for psilocybin. So we've been doing research clinically using DMT-related compounds like psilocybin and ayahuasca for, call it 20, 25 years now. What's the clinical efficacy of DMT? So we have an evolving literature, right? It's not as robust as the literature for ketamine, but it's getting there. That supports DMT's efficacy in treating a wide range of psychopathology. So there's good literature on the use of DMT and related analogs in major depressive disorder, in treating anxiety disorders, and in treating alcohol use disorder. So pretty wide range of diseases that seem to respond to DMT treatment. What's interesting about DMT, it works quickly, not unlike ketamine. So what we see is there's a therapeutic impact in depressive symptoms as early as 24 hours post-administration. So it's not 40 minutes like IV ketamine, but it's still fast, right? When we think about our typical first and second line psychiatric medications today, we're talking about order of magnitude of weeks to months to see therapeutic effects. Here, we're talking about the order of magnitude of days. How does DMT ultimately lead to a reduction in psychiatric symptoms? there are probably downstream effects that include an alteration of perception, a reduction in psychological distress, as well as an augmentation of positive emotions that ultimately help DMT improve psychiatric symptoms across a range of diseases, including depressive and anxiety disorders, as well as substance use. What's really interesting about DMT is when combined with psychotherapy, it seems to have a really long-lasting impact on helping patients feel better. So what we see in the data is actually 2 doses of psilocybin combined with ongoing psychotherapy is actually really efficacious in treating depressive symptoms for up to 12 months. So just to pause on that, right? Patient takes 2 doses of psilocybin over the course of a couple of days, then continues in regular psychotherapy. They feel relief for more than a year, which is pretty amazing sea change from our current medications that require ongoing use, right? Daily for 6 to 12 months to maintain remission. So really interesting research on DMT. So when you think DMT, think about it as a family of substances that includes compounds like ayahuasca, as well as psilocybin, right? These naturally occurring compounds coming from various plants and mushrooms. Think about a wide range of psychiatric diseases that can be treated, including depressive and anxiety disorders. And then think about fast onset, 24 hours, and lasting results up to a year when combined with psychotherapy. Cool. So that's DMT. Now let's flip to the next category of hallucinogen, MDMA, right? Also known by its full name of 3,4-methylene dioxymethamphetamine. So MDMA was first synthesized in the 19-teens at Merck. It kind of sat on the shelf for a while without any real sort of clinical use until some psychotherapists started thinking about it and using it in the 70s. And there's actually some interest in the 70s by a group of psychotherapists about, can we use MDMA to help potentiate the effects of psychotherapy? Sadly, about 15 years later, it led to MDMA being scheduled because of increasing misuse across the country. Since then, MDMA may be better known by its street names. You may hear it referred to as ecstasy, also known as E or Molly. What's interesting about MDMA is, in addition to it being classified as a hallucinogen, it's also known as an empathogen. And what do we mean by an empathogen? We mean it results in sort of this direct and very interesting increase in sociability, which may be tied to some of the therapeutic effects it has. So, synthesized in 1912, some interest in the psychotherapy community in the 70s. In 85, it became illegal. There's been a resurgence in clinical research in the late 2010s, right? So DMT was kind of first around the year 2000. We started thinking of, are there clinical applications? We started thinking about MDMA clinical applications more in like the 2015 to 2018 range. And when you think DMT, think Johns Hopkins as a center of excellence. When you think of MDMA, think of my alma mater, Mount Sinai, as sort of the center of excellence. That's really where a lot of the foundational research has happened around the use of MDMA clinically. And what do we use it for clinically? So the majority of literature around MDMA efficacy in psychiatric disease is in treating trauma and trauma-related illnesses. And most specifically, that means PTSD. And even more specific than PTSD, a lot of the foundational research is in combat veterans, military veterans who have frontline combat experience. So with MDMA, almost all of the literature and studies thus far have been MDMA paired with psychotherapy. And that's a model called MDMA sort of assisted therapy. And you'll sometimes see it referred to as MDMA -AT. MDMA is the furthest along in its journey to becoming a medication. And we'll talk more about that towards the end. But we actually have not just phase 1, but phase 2 and phase 3 trials that show not just safety, but efficacy in MDMA's treatment of moderate to severe PTSD. And how does MDMA work? The very downstream effects are probably potentiated by an increase in pro-social emotion, as well as attenuating or decreasing sort of central nervous system responses to emotionally challenging and fearful stimuli. So when you think of a patient who's experiencing PTSD and undergoing psychotherapy, if you can increase the pro-social emotion and also help them process the trauma without being so triggered, right? And having strong emotional responses to talking about the traumatic incident, I think it becomes super clear how it can supercharge or turbocharge the therapy process for treating that disease. So when we think about MDMA, early 1900 discovery, just in the last 5 to 10 years has become of interest clinically. Think Mount Sinai as one of the centers of excellence, and then think PTSD as really the game-changing indication for MDMA, right? So DMT, we talked about depressive, anxiety, and substance use disorders, and MDMA, think about PTSD. And then the third and final hallucinogen that has FDA breakthrough therapeutic status is LSD, right? Also known as its full name, lysergic acid diethylamide. So LSD was first synthesized kind of somewhere in between ketamine and MDMA in 1938 in Switzerland. It became really popular in psychiatric circles across the world, not just in Europe and the US in the 50s and the 60s. LSD is actually the compound that led to the coining of the term psychedelic, right? So we have LSD to thank for that term. And now hopefully everyone here knows exactly what we mean when we say or use the word psychedelic. In the 1960s, LSD was adopted by the counterculture movement, right? So in the 50s and 60s, it was adopted by sort of the psychiatric community. In the late 60s, it was adopted by the counterculture movement. The American government sort of viewed this as a direct threat to efforts to support or efforts to undermine support for the Vietnam War around this time. And this probably directly led to LSD being scheduled as an illegal substance in 1968. So, from 1968 to the 2010s, LSD was sort of off limits from a clinical perspective. However, in the early to mid 2010s, we saw a resurgence in clinical interest in LSD, particularly given the fact that there was some very interesting work being done in the 50s and 60s that seemed to indicate that it might be useful from a therapeutic effect. So how does LSD work? What's its clinical effect and clinical efficacy? So we have growing literature to support LSD's efficacy in treating both anxiety and depressive disorders. What's really interesting about LSD is a lot of the research and literature so far has been in the absence of guided psychotherapy protocols. So if you remember, with both DMT and MDMA, a lot of the literature focuses on use the compound to sort of unlock or turbocharge psychotherapy. With LSD, it's actually been you take one or multiple doses and the medication, the substance in and of itself, even in the absence of psychotherapy, can help to treat symptoms. And we've seen both phase 1 and phase 2 trials show significant promise in the treatment of generalized anxiety disorder. Okay, so let's pause here just for a minute and zoom out on the 3 hallucinogens we just discussed, right? So we have DMT, MDMA, and LSD. With DMT, think Johns Hopkins, think depressive disorders, anxiety disorders, and substance use. Think fast onset and associated with psychotherapy. MDMA, think about Mount Sinai as being a center of excellence. Think about it being really resurging clinically in the last 10 to 15 years. The primary indication being post-traumatic stress disorder. And it's the furthest along when it comes to clinical research, and we'll get to what that means. And then finally with LSD, think about actual use psychiatrically in the 50s and 60s before it was made illegal, resurgence in the last 15 to 20 years, and strong efficacy in treating generalized anxiety disorder in the absence of psychotherapy, which I think is very interesting. Cool. So let's talk about the clinical risks of hallucinogens, right? We talked about the clinical risks of ketamine, and I think it's only fair we do the same for these three substances. No surprise, the most common side effects of hallucinogens are psychiatric, right? So these are by definition molecules and substances that cause psychosis. They cause hallucination. They can also cause delusions, and they can also cause a dissociation, even though they're not primarily dissociative compounds. So I see a question in the chat about LSD and MDMA having hypomanic impacts on patients with bipolar 1 or 2 disorder. I think we'll talk about this a little bit later. Part of the key to using these therapies safely is going to be the selection of patients, right? And ultimately, we'll have to be really careful in choosing hallucinogen treatments in patients who are predisposed for developing psychosis at baseline. Certainly a patient with bipolar 1 or bipolar 2 disorder is at risk of that. And I think it will only create an increased threshold or increased bar to potentially use an MDMA or an LSD-based therapy in a patient who has underlying, bipolar spectrum illness. So then moving from the psychiatric to the medical risks, you'll see across all three substances a risk for tachycardia and hypertension. And then there are some more esoteric risks with each of them. I think what's most compelling and important for the purposes of this webinar is while tachycardia and hypertension are possible side effects of DMT, MDMA, and LSD use therapeutically, the literature and the phase 1, phase 2 studies that have been done indicate the incidence and severity of those symptoms are dramatically lower than with IV or intranasal ketamine, right? So from a medical perspective, the data we have so far would suggest that these medications aren't going to require cardiac monitoring, right? Or frequent monitoring of vital signs. So the risk for these medications from a medical perspective is actually most likely dramatically lower than ketamine. Where the risk will be higher is on the psychiatric side. So it'll be more important to sort of monitor patients behaviorally when we end up finally using these medications in a therapeutic way. Okay, so we've talked about psychedelics, we talked about ketamine and then 3 hallucinogens. Why are people so excited about this, right? Why do we just spend 50 minutes talking about these? I think if you zoom out, there have been very few step function improvements in the efficacy of psychotropic medicine, since the late 80s and early 90s, right? When the first SSRIs came to market. So these are really the first brand new classes of therapies in 2, 3, 4 decades that we're seeing in psychiatry. And the literature suggests that when used in the right populations for the right indications, the effect sizes of these newly rediscovered molecules can be multiple times greater than the standard of care, right? Than antidepressants, mood stabilizers, or a combination of those with psychotherapy. So this is really exciting stuff. Okay, that's great. Interesting molecules, studies show they're efficacious, but what about the legal status? So all of what we just talked about on the hallucinogen side, MDMA, DMT, LSD, are extremely illegal substances from a federal perspective, right? These are Schedule I substances, meaning according to the federal government, according to the DEA, there's zero clinical use, and without very specific waivers, they cannot be used for any legitimate purposes. That being said, we're starting to make inroads here, right? So as we talked about, LSD, psilocybin, MDMA are the three hallucinogens that now have breakthrough therapy status that have been granted by the FDA and DEA. Specifically, there's an LSD compound from a company called MindMed that has the status for the treatment of GAD. There's a psilocybin compound from Compass Pathways that has a breakthrough status for TRD. And then there's an MDMA compound from Lykos Therapeutics that has breakthrough status for PTSD. So we're slowly starting to see the federal government, the FDA, the DEA, recognize that these compounds actually do have very promising clinical efficacy, and working our way towards a world in which these substances will likely and hopefully be descheduled. And when I say descheduled, I mean descheduling from Schedule 1, meaning no kind of approved or observed clinical use and totally illegal, to Schedule 2 or Schedule 3, meaning there is clinical efficacy. They do have a risk that requires maybe monitoring and compliance, but it clears the way for them to be used as medications. And what is the pipeline, right? So this is just a smattering of what the pipeline looks like today for hallucinogens and next-gen treatments. The one that's the furthest along, which we'll talk about more in a second, is the Lykos Therapeutics MDMA molecule for the treatment of MDMA. It's gone through phase 1, phase 2, and phase 3, and is now sitting in front of the FDA for approval. At the phase 3 stage, we have psilocybin and ketamine for the treatment of alcohol use disorder sitting. So they're running their kind of pivotal trials with large N's and waiting for those readouts to come. One stage earlier in phase 2, there's about 35 trials going on right now with a wide range of hallucinogens. And you just see a smattering here, including DMT, including LSD, including psilocybin, for a wide range of clinical indications. And then phase 1, even earlier, there's about 30 or so trials going on as we speak today, including other hallucinogens we didn't talk about, such as ibogaine and mescaline and others. So this is a very active area of clinical research and commercial activity today. So how close are we to one of these substances being available for us to prescribe and use with patients? Lykos Therapeutics is the closest, right? So their MDMA-based compound for the treatment of PTSD had fantastic sort of phase 3 results. They've submitted now for FDA approval, and it's sitting before the FDA. Lykos is expecting FDA response and, in their hopes, approval in August of this year. So coming up, right? Just 3 months from now. Once that happens, there has to be a kind of a regulatory descheduling. So both the federal government as well as some states will have to deschedule MDMA from Schedule 1 to Schedule 2. It's kind of required, actually, from a legislative perspective. Once the FDA approves it, they have to deschedule it. And Lykos's expectation is the first commercially prescribed doses of their MDMA compound will be administered in January of 2025. So in the grand scheme of things, we're super close here. We're like 9 months away from patients being able to get MDMA with assisted psychotherapy for the treatment of complex and complicated PTSD. So what's the punchline here? We're in the midst of a renaissance of psychopharmacology. And this class, and when I say this class, I mean psychedelics, of previously illegal and stigmatized compounds is showing true promise, right, in revolutionizing the treatment for a wide range of psychiatric diseases, not just depression and anxiety, bipolar disorder, substance use disorder, PTSD, OCD. Ketamine was just the first act here. And its hallucinogen peers may be even more exciting, given their medical safety profiles and their efficacy data. As I alluded to earlier, what's going to be super important with the hallucinogens in particular is the selections of the right patients. Given the increased risk of psychiatric side effects, we'll have to be really careful and have the right processes and protocols in place to make sure we're prescribing it to patients who are going to be able to safely use these medications without unduly causing or inducing psychosis. And then final recap. What are the high-level pieces to take away here? First, terminology. So psychedelics include dissociatives like ketamine and hallucinogens, all the rest that we talked about. What's the mechanism of action? Dissociatives hit NMDA. Hallucinogens hit 5-HT2A. They both have downstream effects on BDNF and neuroplasticity. Number three, ketamine has paved the way with its approval in 2019 and 2020. We think of the primary routes of administration as IN and IV, and there is potentially cardiac risk that we have to be aware of when using ketamine therapeutically. Number four, we have 3 breakthrough designations for hallucinogens over the last 24 months, right? MDMA, Psilocybin, and LSD. And then 5, it's possible and seems likely now that the FDA will approve the first hallucinogen-based compound later this summer. That's the Lykos Therapeutics MDMA compound, which will truly usher in a new era of psychiatric medicine. All right, we made it just in time. There's one question that came through about the MDMA plus psychotherapy being financially accessible. Fantastic question. If you look at kind of the messaging that Lykos Therapeutics has put out, they're actually in active negotiation with commercial payers as we speak ahead of the approval. And the expectation here is that many commercial payers at launch in January will actually cover it. Now, Medicare, Medicaid, TRICARE will be a different story. That'll probably apparently come later. But the anticipation here is that it will be affordable to patients who are using commercial insurance, which will be awesome. Cool. So as I mentioned at the top, we'll send out an email afterwards with the link to the recording. It's hosted on YouTube as sort of an unlisted link. So we'll send that out to everyone. And we'll also include the links for CME credits, so y'all can claim those and get those certificates. Cool. I know we're 1 minute away from the top of the hour. I'm happy to stay on for another minute or two if anyone has a question they want to drop into the Q&A. But otherwise, it's been great to see the diverse crowd and crew that we had here today, and looking forward to seeing y'all at the next one here next month. All right. Well, any other questions that folks have? I'll drop my email into the chat here. You can also find me on LinkedIn. Don't hesitate to shoot me a message. I'm happy to connect on this, talk about this, be helpful in any way possible, and also chat about anything related to soul mental health. Thanks, everyone. Have a great rest of your weeks. Bye.